The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our October 21 Safe and Calm webinar. You will be seeing something a little bit different rather than our regular screen first this morning. We do want to note before we get started that cases are on the rise, but we do hope that they're not increasing in our member facilities. In the past week, the department's speed at issuing new guidance has slowed down a bit, and there are still a lot of issues that are up in the air. One of them is visitation. However, I do want to report that just minutes ago, the department issued its visitation guidance, and at this point it has very few surprises, but we will talk about those provisions later in the presentation. Today we are pleased to be joined by representatives from our business partner, Omnicare, and they will start off our webinar this morning with a review of the Pharmacy Partnership for Long-Term Care program. It's a program that was just made public a few days ago. We will then follow with Dalton's advocacy update and finish our discussion with the usual resources and guidance. So at this point, I would like to welcome Jonathan Arlotta and Akane DiFiore from Omnicare, who will give us a brief overview of this federal partnership program that is intended to expedite distribution of vaccines for our seniors. Welcome.
Thank you so much. Good morning. My name is Akane DiFiore from Omnicare Pharmacy, and first I just want to thank you for your time this morning. Myself, Matt, and many other leaders from our organization have been collaborating with Leading Age in Michigan for many years, and we thank you for that. This morning we'll talk about a very critical and of course time-sensitive topic that Dave asked us to provide some high-level updates on. So we have our fearless leader, John Arlotta, who is the VP of Sales from Omnicare, to share some insights on the heels of the HHS announcement that came out last Friday about the Partnership for Long-Term Care. John, I'll kick it over to you.
Okay, great. Thanks, Akane, and thanks everyone for having us today. You know, we're really excited to have been selected as one of the preferred pharmacies to deliver and administer the COVID vaccine to long-term care facilities once it becomes available. You know, we've had several conversations with HHS over probably the past 60 to 90 days. And, you know, I think there are probably a number of reasons why we were one of the pharmacies selected, but you know, certainly first and foremost is the experience we have delivering our flu clinics, which have a 99% satisfaction rate amongst our flu clinic customers. But as an enterprise, you know, we expect to administer 20 million flu shots this year. And HHS really liked, you know, how this program was structured, which will be very similar to how we plan to coordinate administering the COVID vaccine. Second, I would say, you know, our size and scale. We have over 9,000 CVS pharmacies across the country. We have over 150 Omnicare long-term care pharmacies, but we also have over 30,000 licensed immunizers across the CVS Health enterprise. And we also have the ability to reach, you know, some very rural areas as well. Third, you know, there will be some unique requirements from a cold storage perspective to reporting back to local health officials who was vaccinated with what vaccine and where. And we certainly have the infrastructure and the capabilities to support that. And then lastly, I would say, you know, our COVID testing efforts over the last 6 months has really, you know, set us up nicely to now transition over and vaccinate this vulnerable population. We've already completed 150,000 COVID tests in a number of, you know, long-term care facilities across the country. And then on the CVS retail side, we've conducted over 4 million tests as well. So I think many of you know, the CDC did send a survey earlier in the week to both senior living and post-acute facilities asking them to select a preferred pharmacy provider to administer the vaccine during an on-site clinic. So if you do end up, you know, selecting CVS Health and Omnicare to vaccinate your residents, we will receive a list post-survey of all the facilities that selected us, and then we'll reach out to you folks directly to schedule that clinic. And then on the day of the clinic itself, our pharmacist, will be on site. He'll bring all the requested vaccine product and other supplies necessary, including, PPE for the administration according to, vaccination protocol. And then the last, comment I would make is, through this partnership with HHS, there is no fee for the vaccination. We'll simply bill Medicare, Medicaid, or private insurance. So again, we're really excited and looking forward to moving forward and vaccinating your staff and residents if selected. So thank you.
Well, thank you, Jonathan. Do we have any questions for our Omnicare partners?
I am currently not seeing any questions. So we'll just give it a few seconds just in case anybody is typing anything. And if not, we can go ahead and switch over to our PowerPoint and continue from there.
Okay, I think you should probably go to the advocacy agenda since I have introductory slides already in there.
I do have a couple questions. Who did the surveys go to?
It was our understanding the survey went to all senior living and post-acute facilities. If somebody needs the survey, we could certainly send it out as well. The link to the survey, or takes you to a site where there's the survey. We could follow up and provide that as well. But it was our understanding it went to all assisted living and skilled nursing facilities.
Okay, I did have somebody.
Well, I'm assuming that would mean. This is Deanna. I'm assuming that would mean the administrator, right?
Correct. Yep.
Okay.
How many have already received the request from CDC to choose a vendor?
I don't know that we have, if I understand the question, how many folks have received the survey and the link to select the vendor? I don't know that, unfortunately, I don't know that we have access to that. Obviously, once they do select a vendor, we will receive a list of, who selected us, and then we'll start to do our follow-up outreach at that point. But I don't know that, unfortunately, that we would have access to who's received the actual survey link.
Okay. It says there was something mentioned about it being an NHSN. Has anyone found it in there?
We still talking about the survey link?
That would be my assumption.
Yeah. What might be helpful? We could provide you with the link after this call, and if you have a message board or some way to distribute that out to all the attendees, that might be the best way to help facilitate that.
I have a question. Is the link the same for assisted living and other post-acute providers as it is for nursing homes? We do have, I did include the link for assisted living level providers at the end of my program, but I wasn't sure about if it was the same for nursing homes or not. Are you aware of that?
Yes, I believe it's one link for both nursing homes and assisted living facilities.
Okay, well, we do have the URL for that at the end of this program as well.
Okay, great.
I believe someone is saying that there are two different links. There's a link for SNF and then one for AL.
I thought so as well. So I do have the AL link. I had thought that everyone was going to be sent the other link. The nursing homes were going to be contacted directly. So I included the AL link, and we'll look into any other further information that might be needed for nursing homes in a bit. Any other questions, Blake?
No, not really. Just people saying that they weren't sent them and trying to get the links, basically.
Okay. So thank you, Jonathan and Akane. We will now move on to Dalton's
Thank you.
advocacy update for this morning. Thank you.
Good morning, everyone. We have kind of a broader scoped advocacy overview today, as we're going to be talking about a couple bills that are not yet law, and some that we have talked about before. So you'll see a bunch of similarities today. Specifically, we'll be talking about the bills that are awaiting signature by the governor. That includes that CRC process bill, as well as the designated unit bill. That bill's still awaiting signature, and so is the legal immunity bill, which we'll be covering in a little more detail today, since we haven't covered it in the new version of it in detail. It's been stripped down a little bit. And we'll also be briefly touching on a medication aid bill that we had talked about a couple weeks ago on this call, but it is coming up for a committee hearing, so I just wanted to touch on it briefly and explain where it is in the process. So, as I said, the two bills that really concern us that are on the governor's desk right now are Senate Bill 1094, and this is the bill that requires the state to implement dedicated facilities, the CRC care and recovery units for COVID-19 positive individuals. It also establishes the criteria and process around creating dedicated units. And we talked about this on Friday's call. That bill's on the governor's desk right now, is not yet law. She still needs to sign that for it to then take effect. The other bill is House Bill 6159, which is the bill that provides healthcare providers and workers with civil liability protections for the first wave of the pandemic. And as I said, I just want to be clear, both bills still need to be signed by the governor before they become law. Once a bill is presented to the governor, she or he has 14 days to take action on that bill or not take action. If the governor chooses not to take action, the bills are passively vetoed. But typically you'll see a governor either put their veto stamp on it or sign the bill into law. We expect both these bills to be signed into law, as they were part of a larger negotiations process between the legislature and the governor. And so right now, both of these bills still have 10 days remaining on their clock. So they do have a lot of time. And since these are a little more controversial than some of the other bills passed during that legislative session, we expect her to wait a little bit on signing these. So moving on to discussing the civil liability protections for healthcare providers and facilities, the House bill, I won't read the number again, has been titled the Pandemic Healthcare Immunity Act. And what this does is it provides civil liability protections for healthcare providers and healthcare facilities, with exceptions for gross negligence, willful misconduct, or criminal misconduct. The bill applies its protections retroactively and covers the first wave of the COVID pandemic. Through negotiations with the legislature and the governor, they determined that those dates are on or after March 29th and before July 14th. So that's the date range where, if this bill gets signed into law, you'll have liability protections. And I included a link here to the exact bill summary for you to read if you're interested. It's not a very long bill. So moving forward, in terms of our analysis of this bill, I just want to touch on who is covered, who is considered a healthcare provider, and who is considered a healthcare facility. A healthcare provider is any individual registered or authorized to engage in a health profession under Article 15 of the Public Health Code. These individuals are your physicians, your nurses, your clinical staff, your nursing home administrators, those folks, those who have a license. Medical first responders are also covered under the bill, and student trainees, volunteer, competency evaluated nursing assistants, temporary nurse aides, or any other licensed or registered or unlicensed individual authorized to render healthcare services are also covered by the bill. It's a little bit of a mouthful there at the end, but they really wanted to provide a blanket so that those who are providing the care for individuals with COVID aren't going to be affected by the care they provide unless they willfully harmed someone. Who is a healthcare facility in this instance? The protections were slimmed down from the original bill that we reviewed a couple months ago. in this aspect, because the governor's been a little hesitant on really expanding the scope of this bill. So who is covered? A healthcare facility or agency as defined by the Public Health Code. So who does this cover in terms of long-term care? This covers county medical care facilities, nursing homes or SNFs, home for the aged, hospices, and veterans facilities. Lastly today, I wanted to touch briefly on a medication aid bill, which we covered a long time ago. With everything going on, I doubt a lot of people remember that this bill was moving through the process, so it's always good to have a reminder. The bill is up for a hearing in Senate Health Policy actually at 2 o'clock today. We have been supporting this bill throughout the process. We think would be very helpful for those of us in the long-term care field to offer some flexibilities for how you can use staff during the day. The bill has already passed the House, so it just needs to be approved by the Senate, or the Senate Health Policy Committee, then the Senate, and then it will be sent to the governor. The governor will then sign or veto the bill. Nurses groups have been really fighting this legislation all the way through, so we're kind of, where the governor stands is a little gray right now, but I do think that this will pass out of Senate Health Policy and pass the Senate. What this bill will do in general is it will create a medication aid train-the-trainer-like program for the registration and use of medication aids and SNFs. A medication aid will have to be a tenured CNA and then go through this train-the-trainer type program to then be registered as a medication aid. And what can a medication aid do for you if you do want to have a CNO go through this process? They can administer regularly scheduled medications instead of having to have your nurse do so. But they cannot administer the first dose of a medication, and they cannot administer any controlled substances. I put a link to the summary of the bill right here in case you're interested. The bill is longer than the legal immunity bill, but it's not that long. So if you're interested in that kind of thing, please feel free to take a look.
All right, thank you very much, Dalton. Before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. As of right now, I am not seeing any questions, so it looks like we can go ahead and move. Oh, just had one actually. AFC is not covered in the immunity, but HFA and others are.
Yes, and you'll notice also assisted living isn't in there either. What happened throughout the process? If you remember, we talked about this bill a couple weeks ago. A bill similar to this bill, but with a wider range of protections. Now that bill did not include assisted living either. Was passed through to the governor. She vetoed this. So this bill has kind of been clogged throughout the process because the governor and her constituents really didn't like the scope of the bill. The governor wanted this to be narrowed. And in her veto letter, she said that this bill created duplication with the executive orders. As we all know, the executive orders have since gone away. So through the negotiation process between the governor and the legislature and the political parties, this is kind of where they settled on. It was not a very clean process going through, and this is kind of the best we can hope for. I'm glad something's getting done.
Okay. Unfortunate that nurses.
Excuse me, Blake. Blake, I guess I would wonder why HFAs are not included. Is that what you were saying?
AFC?
I guess I'm not clear about, is there an entity that's not included in the bill that we would be concerned about?
AL and independent living. I think AFC actually might be included. I might just missed it on the slide. I will double check and I will get that out to you.
Okay, great. I think that'd be good because it should inform our advocacy if that indeed is the case.
Yeah, I do know independent living and assisted living are not covered. because that's what kind of we were talking about, and I must have just misplaced it in my mind when I answered the previous question or when I made the slides last night. Apologize for that.
Okay, thank you.
All right, and then this is more of a comment. Unfortunate that nurses are fighting the medication aid. I am an administrator/DON and think with proper training this will be good for LTC. It will give nurses more time for assessments.
That is an argument we have made to the legislature and to various staff members, but I can't always explain the reasoning for why other constituencies do what they do.
Well, this is Deanna. You know, the nurses have long been opposed to anything that takes away some of their responsibilities, and they have really been the barrier for all of these years. And we agree, and even I as a nurse believe that you shouldn't have to tie up higher level clinicians, nurses, in passing medication. So we have always been a strong proponent, but the nurses have a strong lobby. So we'll have to see how it plays out this time. We keep hoping that it will pass.
All right, now it looks like that was the last question, so we can go ahead and move on.
Okay, great. So we are going to do a very brief situation update. Today, it seems even more important that we talk a little bit about the data because there's so much happening in Michigan. So, Blake, you can move the slide forward. So for months now, I have been waiting for someone to tell us that the second wave has arrived, and somehow or other I missed some major information. So that second wave was supposed to come in the fall when the flu season started, I thought. And as the cases went up, I thought we were approaching it. And then to my surprise, Johns Hopkins and some other experts started talking that we were in the middle of the third wave, at least looking across the United States. So this slide kind of shows you how they came to that conclusion. The second wave included a large number of younger persons, and then following that, we had seen a larger number of infections in older persons, well, about 3 to 4 weeks later. So people are saying now that it looks like we are in a third wave, and if you look at the daily caseload across the U.S. over time, it certainly looks that way. When we look at Michigan, however, the second wave, if it did hit, was relatively mild, and a lot of people are saying that that's because of the strong protections that were in effect. So it's not as obvious that this is a third wave here in Michigan as it might be across the state. However, we can clearly see that for the past week, we've had a major significant increase in cases. And the arrow that's there is pointing to where we were 7 days ago. So we have had that huge spike, rapid increase just since October 14. And so that's really significant and maybe kind of a warning of where we're headed for the winter. In terms of deaths, we also have seen an acute rise, although they, of course, are nowhere near the rate of increase that you'll see in caseload, and hopefully our treatments and our early identification of cases is helping to some degree. But we are seeing a rise there, and of course, we'll continue to track that. So in looking at just the Michigan active cases, you can see that we are approaching the same numbers that we had when we peaked in April. And of course, the cumulative rate, which is that red dotted line, will always continue to go up. So as of last night, the case positivity rates were unchanged on the Nursing Home Compare website, so I didn't really include them here. The MySafe Start Map itself, I'm not sure about this morning, we'll talk about that in a minute, but looked the same as it did before. So the risk levels for all of those major regions were the same. However, because of the visitation guidance, my understanding, which just came out within the last half hour, there is a list of each county in Michigan on the My Safe Start page, and it will tell you specifically what the risk level is for each of those counties. So that's the data that you're going to need to look at your visitation ability, for lack of a better word, going forward. I have not myself looked at it yet, but we have looked through the guidance a bit. So this slide, again, shows that the regional risk levels are the same as last week. But look at the test results. We went up from a 3.8% positivity rate last week to 4.7 this week. And we went from 82.6 cases per million to 112. And we're averaging about 1,120 per day for the last 7 days. So again, we are seeing significant increases in cases across Michigan. So on to a few updates. As we've heard a lot from members over the last 7 days. We've gotten a lot of emails with questions, and a lot of it has been about the immense confusion, considering that the executive orders are, at least those are related to the emergency, cannot be in effect past April. And now we have emergency orders, epidemic orders, we have other guidance that are driving the regulatory environment. We're getting stuff from Laura, stuff from the FDA and HS, and it's no wonder that everybody is a little overwhelmed. Over time, I at least keep thinking that they can't keep changing things forever. They will get to something that will be stable. However, after over 7 months, it seems like we still have not quite gotten there. One of the messages that I want to make sure that everybody hears is that pretty much all of the essential pieces that affect residential care, senior care environments are the same because they have replicated them in other orders. So between what's come out from Laura and what's come out from the department and with CMS and CDC, very little, if anything, has changed. So if you think that you're questioning whether or not something is still active in terms of a provision, please do email us. But I do want to assure you that very little in your practice should be changing at this point, simply because the executive orders may have gone away. So yesterday, we did receive a direct message to us from MDHHS. And they wanted to let us know that 139 facilities last week failed to report their data, and they will be getting a civil money penalty for that. So they specifically asked us to remind everyone that reporting is still required and that facilities should be checking any notices that may be sent via Casper and to ensure that they're reporting every week. Your CMP will come through Casper, is my understanding. It will not come from the survey agency as with other citations. So just a reminder that reporting is required. This next piece is about the NHSN reporting pathway for point of care testing. And I read, I don't know how many versions of this. It's still a little bit confusing to me. I think I understand what they're trying to do. It just seems that the program reverses the data path for point of care test reporting in nursing homes. And this pathway, though, will be available for assisted living as well if they choose. But considering how we are now transmitting data to NHSN through the state, this seems to be a roundabout way to do it another way, at least for the point of care tests. So the module allows nursing homes to enter point of care data directly into the NHSN program. And then NHSN will report the point of care data directly to the public health agency, the state agency, or any local agency that has responsibility over your data. So through that process, de-identified data will also be reported to HHS. And I think that's what the goal is here, to make sure that point of care data gets to HHS because normally the testing data would have come to HHS from the lab. And we know there's no lab interface here for point of care testing. So this is the CDC process to take care of that. However, the current flow of information to NHSN currently goes through the state system, EM Resource here in Michigan, although some enter their information directly into both systems. So it just seems a little complicated to us, and at the same time, in order to use this system, all of our members would have to have level 3 access to the system through SAMS in order to use it. So we did reach out to the state for some guidance here, and they replied that the state through EM Resource actually already reports positive and negative testing to the CDC. And our understanding is that if the state doesn't choose this reporting platform, no providers in the state can use it. So Leading Age National believes that this new pathway may be a requirement, but it's not so far, but they're concerned about the duplicating systems here, and that one system is one way and the other system is the other. Michigan, after talking to them a bit, the state has not developed any plans to date, and this memo is only a week old, so we're going to have to see how it plays out. But if HHS starts requiring it, then I guess we're going to all have to shift some more. So there are 2 trainings on the point of care reporting program. They are scheduled for Thursday and Friday of this week, and those are the links that you can use to register. Note that they are not different programs. One is just a replication of the other. So if you're interested in knowing more about that point of care pathway, I suggest that you try to sign in on one of these training dates. And for those who are still working on elevating their access to NHSN to level 3 using SAMS, I just put a step-by-step guide here in this slide that will help you do that. We're certainly not going to go through it, but this is the process you'll have to use to increase your access level to 3. So we got a couple questions this week. One was, is Michigan able to enter data related to point of care testing on the NHSN? And this is where they responded that indeed, they do already report the testing. However, they are not using the new pathway, obviously, yet. The second question was, is there a Michigan plan to vaccinate staff, like the partnership with it says CMS, but it's supposed to say Omnicare and Walgreens. We don't know of any specific plan on Michigan's part. We do know that they were planning to figure out how to distribute vaccines, but indeed, if the federal program works, we're not sure that they're going to do anything yet. We've yet to talk to them specifically about their response to the federal program. And last week, someone asked if the recent rise in positivity rates could be related to the non-reporting of point of care negatives. Right now, you are required to report them through EM Resource, according to the state, and they say that all of that data goes to the local health department, so that technically any changes in positivity rates should be actually representing what's going on in the community. Provider Relief Fund infection control payments. We talked a little bit about this last week, but they keep giving us a little bit more information all the time. So there are 2 types of criteria that you have to pass just to be eligible, period. The first is the nursing home infection rate. It has to be lower than that in your county, and your mortality rate must be less than 10% of all the persons who have COVID in your facility, and that would include persons who came in with COVID, who were not facility-acquired COVID residents. So your mortality rate for COVID has to be less than 10%. So if you pass that criteria, you're eligible for payment, and the amount of that payment then is based on your infection rate adjusted by your mortality rate. Now, how they figure that out and how they identify how much money you'll get in an incentive payment based on that isn't clear. But the mortality measure will change your payment rate that's set based on your infection rate no more than 20% up or 20% downward. And it is risk adjusted for age, etc. So our next slide is the chart that describes the performance period and the payment period. The monies that are supposed to be distributed for October are scheduled to be out by next week. About $400 million is going to be distributed each month. And then there's also a final payment that looks at performance across the entire 4-month period as well. And that payment will be distributed in early 2021. Right now, CMS estimates that between 65 and 70% of nursing homes will receive some sort of payment in October. Okay, so we got a little bit of a curveball this morning. They sent out the visitation guidance just minutes before we started the webinar. So I quickly threw a couple slides together. Most of the requirements are here. I did not put 100% of them in here, especially those that were already in place. Basically, when we looked very quickly at this guidance, all of the other requirements are still in place. They simply added the ability to have indoor visitation depending on mostly risk levels and testing. So that's the way to kind of think about this. You must prohibit entry except as follows. In other words, technically visitation is prohibited unless you can maintain the additional protocols. You must have had no new facility acquired or staff cases in the past 14 days. You must be residing in a low A, B, C, or D risk level. There is no indoor visitation if you are in an E level area. And they are talking about counties now. Remember, I said earlier that the county list with the associated risk level is supposed to be on that website right now. So outdoor visits only are allowed in E, although E also, ADL and end-of-life visitation is allowed for every risk level. So outdoor visits, though, only in E, except for those exceptions. And the local health department would have to not prohibit visitation in your facility based on what's going on. So they have some ability to stop visitation as well. So here are like most of the requirements that were there before. By appointment only. There's still, you can still place some time limits on the visitation time. You have to log in, log out, provide contact information for the visitor, attestations that you're going to report any symptoms of COVID. 2 visitors only per resident. Testing, we're going to talk about testing requirements a little bit later. Designated entrances, screening, signage, physical distancing. Physical distancing is required except for persons who are providing ADL care. However, those persons do have to provide such care with appropriate PPE. For end-of-life visits, contact is okay as long as the resident is not COVID positive. And of course, as usual, you have to have adequate staff for transitions and disinfection and monitoring. So for outdoor visitation, same requirements. 6 feet in distance, tables are recommended, marked areas and signage is recommended. You have to have disinfection after use. You have to have added protection from the elements, and you have to have some monitoring. There are no restrictions on window visits, and in fact, you have to allow them for all your residents. So if you have residents on second and third floors, you have to figure out how to get them access to a window on the first floor. Parents or guardians are allowed for anyone 21 years or younger. I do know that nursing homes aren't allowed to have anyone under age 21, so this should not affect nursing homes. But also remember that this visitation guidance, which I think I forgot to say, does cover all of the same residential entities as before. So it isn't just nursing homes, and it isn't just homes for the aged. It's independent living, unlicensed assisted living, and AFCs as well. So for ADLs and end of life, now this is a new piece, and we were not warned about this piece, but we can see perhaps the long-term care ombudsman's voice here, except for situations where the visitor is COVID positive. If you are denying someone an ADL visit or an EOL, end of life, compassionate care visit, you have to provide a written explanation of why such visits are denied. And these denial notices must be sent to the department and to the long-term care ombudsman. I do know that this has been an issue for the ombudsman all along, that they felt that some facilities were denying visits when they didn't really need to. So I'm sure that this is in response to that. Testing. Visitors must be tested prior to indoor visitation in risk areas C and D. So it's not required for end of life. And I think the previous draft said within 72 hours. Now they're saying the same testing requirements as for staff working in the facility. And that 72-hour piece was, we thought, going to be problematic, because we know that if visitors go out and be tested, they may well not have results for 72 hours. So if you have to have a negative test within 72 hours in order to visit, that didn't make a whole lot of sense. So now they're saying, and remember that we have not had a chance to talk to the department since this came out, the same testing requirement as for staff working in a facility. What also is unclear is how HFAs, AFCs, and independent living are going to have to get testing, get physician orders for testing, etc. Those issues came last week, and they are on our list for discussion with the state as well. Testing is required for C and D level risks and for indoor exception visits in E. So remember that the only kind of indoor visits that you can have if you're in an E level area are those exception visits for ADLs and end of life / compassionate care. And so testing would be required for those visitors. So I think that there's a lot of questions out there about testing yet, and we will try to get some answers from the state. So now, these are the slides that I had originally. So some of them are not updated. These are some of the questions that we got in the past week or so for visitation. Is the testing of visitors required for HFA and AFCs as well? My understanding, it is for all three of those entities there. I actually did not think originally that it would be, but it does appear like it, but we're going to have to work out how that's going to play out here. And of course, this response here is old and inappropriate. Someone said they're using the BD Veritor rapid test for screening compassionate care visits now. Is this still okay? We see no reason why it would change. And in fact, we think that probably the point of care tests are the most easy way to get visitors tested. Do we expect more specific instructions with respect to the type of visits? And those are the things where you can have the visit, limitations on the number, limitations on the time, etc. All those things are still in place, and we had thought that they would be. How do we get testing info from visitors? Again, we would suggest using the point of care testing. If that isn't the case, they have to present a test report. And someone asked if we have to validate it. It's unclear that, well, let's say that there's no requirement that we can see that you would have to validate it. And of course, some of these other pieces that I wrote yesterday are old by now. Someone asked and said that it isn't clear if outings provided by the facility are allowed. Can residents go on outings in facility-driven vehicles? So this question has never come up that I can remember. There is no guidance otherwise, but and it's important to remember that you can't stop anyone from leaving who has the legal right to do so. But with the transmission level that we're in right now, outdoor non-essential trips are still meant to be discouraged overall. So I think it would be kind of hard to promote one and use a facility-driven vehicle because vehicles are close. I don't know how you would maintain distance and figure out how to get enough people for the outing in the vehicle. So I think that they would be discouraged, but there is no written guidance that says that anywhere. I do know that there is guidance that says educate residents about going out unnecessarily, and if they have to go out or they choose to go out, what the safety precautions should be. If tents are okay, can we use an enclosed porch? So we've gotten an awful lot of questions about what kind of structures are okay out in the world to meet the expectations that they would have for outdoor visitation. So we do know that tents are okay because the state sent out the requirements, the national level requirements for tent safety. I did we did reach out to the department and ask them what their expectations were for outdoor settings, and they completely turfed it to your local fire marshal. And I'm a little concerned about that because although the local fire marshal can tell you what's safe, they may not necessarily be able to tell you what kind of a outdoor structure would still meet the requirements for outdoor visitation. It could be ventilation, it could be all sorts of things. One member told us that they'd heard that the state of Michigan considers anything with 4 walls, even a tent, to be indoor. And that's not the case. And in fact, when we talked to the department, they stood down about this completely and sent everyone to consult with their local fire marshal and maybe your local health department. So there's no specific definition here. We will keep trying to work on it, but they didn't give us an answer that was really helpful. So a bit about care and recovery centers. One of the reasons why I wanted to go through this is because we've gotten a lot of questions about this, and technically there's 3 levels of guidance that's covering this right now. So there's the original regional hub guidance, which is evolving, and eventually regional hubs are supposed to either go away or they can transition into CRCs, those care and recovery centers, if they meet the criteria. However, until there's enough CRCs standing, those regional hubs may still be out there working under the old rules, kind of grandfathered in until some transitioning could be done. So the department also has new guidance and applications issued for their new CRC, Care and Recovery Center program. Those rules are mostly about higher performance level in terms of meeting the basic requirements, and also some structural, how you have to be physically laid out, your staffing, etc. And so those requirements are a bit higher than they were for regional hubs, and probably for good reasons, since some of the regional hubs didn't meet a lot of performance criteria. And then last but not least, and this is the piece that I think is confusing, is that there's the CRC bill out there. However, still, as Dalton said earlier, that has not been signed. So if looking at that, those are even more requirements, and those requirements are not in place yet. So if you're looking at how to use the CRC, or if you want to be a CRC, right now, that bill is still kind of hanging out there. So I would suggest you not really think about that, but base your decision on the new guidance and applications that the state put out. There might be some new rules about it. I don't think that they're a tad more restrictive in some ways, but basically they're not that different. I think that the main difference in the CRC bill is how they're used, how those centers are used, and what some of the requirements are for using them as opposed to what you have to be. But again, that is a bill, and it has not been signed by the governor yet. So someone asked the following 3 questions. Is it true that CRCs have to take all COVID admissions if they have capacity? And yes, that is true based on the current guidance. And then they also asked a couple other questions. Those questions or those requirements come from the bill. So the CRC must be filled before allowing a local nursing home to serve any COVID positive person. That's in the bill, it's not in the guidance. And that kind of might color how you might think about becoming a CRC, but again, it's the bill and not in place right now. And there's also additional criteria in the bill that must be met for any standard facility to accept any COVID residents. So this would be a criteria that's beyond the current department expectation for cohorting developing a dedicated unit in your facility. And again, that is in the bill. It is not in the guidance. So if the bill is signed and the department updates their guidance, these rules may apply, but it depends on whether the governor signs the bill and when. Testing. A few basic testing questions. We keep getting this one question over and over again. Is it true we have 72 hours after admission to test new residents? And the answer is no. You are required to test on admission unless the person has been COVID positive in the past 3 months, or if a COVID test has already been conducted, usually by the hospital, we would think, in the past 72 hours. So technically, you're supposed to test on admission. And in fact, I think this is really important because we had a member last week who did a point of care test directly on admission within the hour and found it to be positive. So that admission piece is probably important to know what the resident status is, at least as of that moment. We had someone who had a staff person who tested positive on October 15th. And they tested all the residents on October 15th, and they plan to test on 10/22. Would that be sufficient? And the question here is that, well, that's twice in a 2-week period, more or less, but that wouldn't be sufficient in terms of the CDC requirements. You would have to test someone also around 10/29. That would be the end of the 14-day incubation period. So we want to make sure that when you're looking at your 14-day period, for outbreaks, that indeed you're covering the entire 14-day period. Another question, do I have to report staff positives to the HFA licensing consultant, or do we just residents? Per HFA, AFC FAQs, you have to submit an actual incident report for any staff positive if you're an HFA, not if you're an AFC. And we assume that that would be informing the licensing consultant as well. This is an important question, I think, and it came up last week. Are testing funds from the state or are they from the federal government? How does that impact our reporting for provider relief funds? Because you have to consider all your federal funding when you look at your reporting. So we put that question out to Plant Moran, and we're hoping that they will get back to us soon. This, I find, is a little, how can I say this? This is not as, the next one is not as accurate. What are the timelines for notifying of positive COVID cases? So it says you have to notify everyone within 24 hours in the epidemic order. But, the new guidance that just came out, and I think that there's another section that says something separate in this epidemic order. You still have to notify residents and staff within 12 and everybody else within 24. So I will correct that in our Q&A. Outbreaks and quarantines. This is the case that I was talking about a minute ago. The resident was tested and found positive immediately on admission. They wanted to know if they needed to put in full outbreak precautions, and the answer is no. Anyone who is found positive on admission or within 14 days of that admission is not considered a facility acquired case. It is not an outbreak. You have to, of course, do all of your standard precautions, but you do not have to put the facility in a lockdown sort of state. The local health department is stating that we will have to isolate in a nursing home for 14 days any persons going out for appointments. So even though we had guidance from the state survey agency saying this was no longer true, we went ahead and reached out to MDHHS as well just to confirm that that was their thinking. And they did confirm that the local health department was wrong. The long-term care ombudsman also agreed that they were wrong. So the survey guidance that says that you no longer have to isolate and place these persons in transmission-based precautions, that still holds. Another question, do we still have to quarantine new residents with full PPE for 14 days, or has that changed? And that has not changed. You need to quarantine and use full transmission-based precautions if you're a nursing home. Without doubt, you will get cited otherwise. This was an interesting question. The CDC uses a symptom-based methodology to discontinue transmission-based precautions for persons who are known to be positive. But they also identify that you can use a test-based, you can have a single test, according to the CDC, that's negative, to get someone out of observation. So, and they talk about how to do that more or less. I'm not going to go through all of this requirement. Basically, you can use a symptom-based strategy to get someone out of observation, such as a new admission, but they also say that you can use a test. And so a member was saying, well, why can't I do this? And the reason why you can't do this is because you will get cited because CMS will not allow it and the department will not allow it. So I put the memos that are there, and basically you're going to have to use full transmission-based precautions for any new admission for 14 days. That's all there is to it. The CDC guidance would be superseded by these other requirements. So the question then related to that is, must homes for the aged or a SNF place a new admission in that 14-day transmission-based precaution if they received a COVID test in the past 72 hours? So the SNF still has to do that, as we just talked about. But when we look back at HFA guidance, HFAs are allowed to do that, and they should consider local-based transmission. They should be conferring with their local health departments, but they don't have to do it. However, they do have to ensure the safety of their residents. So it would certainly, considering transmission rates right now, probably be the prudent thing to do, but there's nothing written in Michigan that says that a home for the aged or adult foster care has to put someone in full transmission-based precautions for 14 days. Can family members transport residents to medical appointments? I have never seen any restriction on family members doing that, other than, of course, they do want you to stay in the facility as much as you can, use telehealth as much as you can. But if you have a medical appointment that you have to get out to, there's no restriction on families transporting. Some general questions. We got a question about directed plans of correction and whether or not the entire board of directors had to sign the DPOC before it went in. So we reached out to Michelle Repke at Laura, and this is her direct response. The intent is to ensure that the board knows about the plan of correction and that the root cause analysis was discussed among the QAA committee and board members, and corrective actions were put in place, and so the board is aware of all of that. So the board chair signature alone is enough that states that the discussion took place and that they are signing on behalf of the governing board. That would be acceptable according to Michelle. Can we really open up communal dining and group activities? The epidemic order is not clear about that. Yes, and we have to fully admit that the epidemic order from 10-6 and the resulting one that came out this morning, I think they're calling it a residential order, isn't very clear. But we did confirm with Kate Massey, following that order being issued, that MDHHS currently has no guidance that would prohibit communal dining or group activities, but that CMS does. And they referred at that time to the recent guidance that came out in QSO 2039. Are volunteers allowed in a SNF? I apparently didn't write a response to this. Volunteers are allowed, but the only provisions that address what they can do is in the visitation guidance, and it talks about their 4 or 5 roles potentially for visitation. So they are allowed for that piece. It's not clear at all that they're allowed for any other activities. Do we still have to fulfill the 12-hour training requirements for CNAs? That's still covered in a blanket waiver. So they have postponed the requirements for the 12 hours of training annually until the end of the pandemic. So the answer is no, you don't have to right now. N95 usage. Some members, a couple of them over the past week, have not been using N95 masks for persons under observation, including new admissions, but rather have been using surgical face masks. Will they get cited? So if you go back to the recent survey or guidance that came out of Laura just a week or so ago, it requires specifically an N95 mask for all new admissions and anyone under transmission-based precautions. And we reached out to Margaret Chamberlain from Rolf, and she confirmed that for us. And Margaret will also be with us tomorrow during our regulatory day to discuss other recent citation issues. So this is a list, and I know it's a partial list, of issues that we're still struggling with. I think that I know that it isn't a thought, it's really something that I know, that over time with all of the communications going back and forth, that there are some gaps in what we're following up on at times. So now and then I will put an issue list out here, and I'll want you to specifically add to it because I know it probably does not represent everything that you're struggling with. So what I have now is a lot about the visitation and testing requirements for independent living and assisted living. The second question is probably moot. What will we do when visitors cannot get results within 72 hours? Because it implies in the new guidance that just came out that you you probably need to test weekly for these visitors. How will Homes for the Age get point of care testing? We are reaching out to Leading Age to ensure that persons who are trying to get CLIA waivers and point of care tests might need some help. They have been very helpful in with nursing homes, so we're hoping that they can help us as well. We've reached out to them for some guidance, and of course, we're still looking for more information about reimbursement for testing costs for any visitor testing that might be required. I do know that there's more. Either put some in the chat box for us now, things that you're struggling with, or by all means, email us at safeandcom at leadingagemichigan.org. So here is the link that I know for the assisted living and the pharmacy program that I discussed earlier. I did know that they had, I thought they had a separate link. Now for the nursing homes, I did think that the nursing homes are going to get an invitation, but assisted living people are supposed to request to join this pharmacy program, and that is the link for them to do that. So I know that was a lot of stuff. Go ahead, Blake.
Yes, I'm just going to hop right into them because I believe we have probably around 25, 30 questions would be my guess.
Okay.
Just to clarify, HFAs no longer need to report in Survey Gizmo as per David Herbal's email on 9/30/2020.
I'm sorry, you're going to have to repeat that.
Just to clarify, HFAs no longer need to report in Survey Gizmo. And then it said as per David Herbal's 9/30/2020 email.
That's my understanding, yes.
Okay, for the COVID mortality rate measure, what time frame?
The time frames for both the infection measure and the mortality measures are, I think, on the slide. Can you flip back to that earlier slide, Blake? It's pretty early in the resource group.
You're just gonna have to tell me when to.
Well, it'll be a table. You'll see it. Okay, stop.
Yep.
Go forward. Okay, there it is. So the performance period date range is for both the infection control piece and the mortality piece. So for the payment that you're getting in October, the performance period was August 31st through 9/27.
Okay. IL is not covered in the new order. What does this mean?
I don't know. I scanned that order very, very quickly before the webinar. I will look at it again to see what it says. If indeed independent living isn't covered, I'm not sure if it means that I can't imagine it means that you don't have the ability to provide visitation. We'll see if it's just a missed piece or what the department's planning.
So can we now have indoor visits with following the guidelines you posted? Is this starting now?
Again, I only scanned the visitation. I didn't see a date, but I didn't look for it. I was just trying to get the elements. I would refer you to the guidance. I'm sure we'll be sending it out. I don't have a link to it in this piece, and we'll be looking at that. I also need to say this, that I know there are a lot of questions out there. What we don't get to, we will put in our update for this afternoon, because we have a hard stop at 11:30 just in case. We don't usually go to 11:30, but sometimes we've gotten close. We have an MDHHS meeting at 11:30, and so I have to have a hard stop at that time. Okay, Blake, next question.
All right. Do the infection control grants earned during September to December have to be supported by increased expenses to be retained?
I believe that you do have to have the same reporting requirements, and I think that there was something about staff support in there as well. I think Dalton is better understands what the reporting is for the provider relief grants than I do. But we will review it and perhaps send out. I think that we did a summary of some of it somewhere, but I'll find it.
This testing requirement seems to be only required for SNF. Do you read this the same as me? C2C3. Again,
I scanned it, so if that's the case, that would be good. And that was what we were hoping for. And I may have just missed that, literally scanned it in 5 minutes before the webinar. So we will look at this in detail and put out a little bit more clear guidance shortly.
Has the updated visitation guidance discussed today been put out, published somewhere that we are able to find it?
I believe they send these things out directly to facilities. I have to get them in a roundabout way. So usually by the time I've gotten it, you all have already gotten it. Sometimes they put it out through the MyHand. Sometimes they send it directly to the administrator. I'm not sure how they sent this one out, but we will make sure that everybody gets it.
All right. Someone said the 72-hour requirement is still there. C3A3.
Oh, okay.
Are we going to be expected to do a POC test on a family member if they are unable to get tested on their own?
I don't know. That's a good question. I would think that you'd want to foster visitation if you could, but then again, I think partly it might depend on whether or not the state's going to reimburse for it, and that's something we're going to ask this afternoon. So we'll have to see.
Okay. Do we have to test independent living visitors, and how do we do that after office hours?
I'm not sure how to answer that yet. We'll have to look more into it to see who's even covered here. Again, I apologize for that. I only had a few moments to look at that guidance before we went on live.
Okay. Don't you need a doctor's order for a POC test? How do we cover this for visitors?
Yes, that was one of our questions earlier. That's going to be a dilemma. So that is one of the barriers we think that's going to be out there, and we will be talking to the department about that.
Can we charge visitors if we do the POC test to help cover the cost of replacing the supply?
I'm not sure. It might be that the department might cover visitation testing. Again, we don't have enough information to know that yet.
Okay. So SNF are to COVID test the visitors using a rapid test prior to entry, and they need to be tested weekly?
Again, that was my read originally. I would have to ask the department. I don't understand the difference between the requirements. There is a line in there that says they're required to do testing just like any other staff. But I don't remember this 72-hour thing. So I was thinking maybe on a weekly basis, or maybe it's 72 hours if you're not coming in on a weekly basis. I'm not sure. So how to operationalize this is still kind of up in the air. And we will go through it in detail again and try and get better guidance out shortly.
I just checked the Michigan Safe Start map, and Washtenaw County is an E-risk level, but on the CMS site it is 1.9% and green through 1014, and Region 1 is still rated as a C. Why does the state's county rating system vary so significantly from that of CMS?
Well, first of all, the state system is going to be reflective of very current transmission rates, and it isn't simply positivity alone that warrants a risk level in Michigan. So I believe that Michigan looks at a larger set of things, which has not really always been published, in order to determine their risk levels. I do know that since transmission has gone up remarkably in the last a week or so, that it doesn't surprise me. And also, I have to tell you that University of Michigan is sitting there, and they've had a huge problem with students and COVID. So it makes sense to me that that area would be an E.
All right. Somebody did say that the effective date is October 26th.
Okay, great. Thanks. It gives us some time to think about it.
Okay. Just to clarify, long-term residents leaving the facility for appointments do not need to be placed into 14 observation when they return.
That is correct.
Is HFA still required to do testing upon admission, or is it sufficient to have one within 72 hours prior to admission?
Let me look into that.
Okay. If a family transports, would we have to place the resident in isolation? This seems concerning if a resident is in contact with family members with no PPE.
Well, my understanding is that I don't know if this is a SNF or an HFA or what, but it should, the requirements might be different, but the action should be the same. If you send someone out to an appointment and family are transporting, they have to maintain all of the safety protocols, and you should be identifying what those are. You might want to put someone in the back seat. Everybody should be wearing a mask. People should not be touching each other. They should be at least 6 feet apart whenever they can be, etc. And when they return, you need to screen them. And one of the things that is pertinent about these visits outside of the facilities that you should be asking about who they were in contact with, were they able to maintain everything, because then otherwise it's your decision if you think that someone could have been exposed to put someone in observation if needed. So if someone's been exposed, that's a whole different ballgame than if someone is simply been admitted under observation. So those requirements and safety precautions are often up to the facility, but you are not required simply because someone goes out to a medical appointment to put them in transmission-based precautions for 14 days.
Okay. Where is the requirement found that requires the board to sign a DPOC?
It's in the directed plan of correction information, and I don't have current ready access to that. I'll have to look for it. But Michelle Refke is going to talk about that tomorrow during our regulatory day as well. They said that was in the guidance, and our member was referring to it in guidance, and Michelle responded, so it must be there.
Can a CNA allow their certification to expire at this time?
I believe that that's still under waiver, but let me check to be sure.
Is the November 1 deadline still in place for CNAs who have not passed their CNA test, meaning that these employees can't work as of November 1?
That's my understanding, yes.
Is there still a waiver in effect for the nursing assistants and their testing for certification?
No, I believe that again, people are supposed to be certified by November 1 because most of the testing is now available. But we can review that guidance. There is a website on the LAURA system, Licensing and Regulatory Affairs System, web pages that speaks to this. At this point, everyone's supposed to be certified. Now, whether or not they have to ensure that their certification is maintained, whether or not that piece is still under waiver, I'm not sure about. I will check.
Okay. Someone says independent living facilities have been removed from this order and the related requirements no longer apply in those settings. And then it's in parentheses, Aaron Emerson, MD, HHS.
Great. Okay. We'll talk about that some more.
Do you think the pharmacy link is also for IL? I am confused if IL are included in the vaccine protocol.
Pretty much, I think that I heard that was for assisted living. So we'll have to look into whether or not independent living facilities can use the same link. I had thought that they were included in the program, so I would think that maybe that link is for them. I think the link is for those people that are not known to HHS, and nursing homes, of course, are all known to them, and the other facilities are not. But we can check into it. I would believe it probably is.
Oh, okay. Someone says, I suggest subscribing to the MSP press release request as I always get them quickly this way.
And that's how I actually get most of these as well. In fact, I got the MS, which is the Michigan State Police. If you sign up for their messages, I got that before I got the message from the department. The department sends us out usually things after they send it to you. But I got the notice this morning from the police faster than I got it from the department.
All right. This is also just a comment. UM students now under a stay-at-home order, FYI.
Exactly. I know that there's a major surge at U of M.
Can you repeat the difference in allowing communal dining and activities in SNF versus HFA and the QSO you referenced?
Okay, so there's been a lot of controversy and discussion about this, but my understanding is that even though the QSO 20-39 is for nursing homes, that is what the state is relying on. There's not a whole lot of requirements in there for communal dining, and they all make sense for all settings. And those are requirements that are to be applied for every setting in Michigan. Since there is no department guidance for communal dining and group activities, they are deferring to CMS for all settings.
Okay. Per the new MDHHS order, residential care facilities means a nursing home, home for the aged, adult foster care facility, hospice facility, substance use disorder, residential facility, or assisted living facility.
It says residential facility?
Residential care facilities means a nursing home, home for the aged, adult foster care facility, hospice facility, substance use disorder, residential facility, or assisted living facility.
Okay, so in the past, residential care facility under the state sometimes meant independent living, but we will check into it to see if that's included.
Okay. Can you please again state the N95 requirement, and can you share where it can be found on the LARA website?
Okay, first of all, it cannot be found on the LARA website. They have not published that. They did allow us to share it with members. It is the guide to the surveyors. And for almost all transmission-based precaution scenarios, N95s are required. I will try to remember to send it out with the update this afternoon in case you don't have the link. We did send it out, I think, a week or so ago. So it's in a member update from last week, but we can resend it today.
Okay. Where can I locate the information on indoor visits for a SNF?
That is the guidance that just came out. We will send it out. I think it's probably on the resource page under MDHHS coronavirus, if that's what you want to Google. The department has a page for that. They put all of their epidemic orders and emergency orders there on a list of resources, and we will also send it out this afternoon.
Okay, where is this specified written now that residents leaving the facility do not have to return in the 14-day observation?
That's in the surveyor guidance, the LARA guidance to surveyors that we sent out about a week and a half ago. And again, I will include in this afternoon's update because it is not a published document. It is a document that we were allowed to share because technically it is a guide for the surveyors, but it tells the surveyors that they can't cite for that.
Okay. If we cannot properly fit an employee for an N95 mask, fail multiple fit tests, how do we protect these employees and the residents that are cared for by these employees?
You know, that's an important question, and I heard a comment last week from someone saying that close attention to the fit test requirements has not really been an issue for the surveyors, and some of these masks probably are better than surgical masks, even though they may not be fitting tightly. However, I don't really know that in particular. We're trying to get a fit test expert to talk to us, but also one who understands what's going on in terms of survey in Michigan. And if we find that person, I will definitely rely on them to give us a better update, because I'm not a fit testing expert.
Okay. Just received the new order. It states non-medical service providers such as hairdressers and providers of religious services are not allowed. This is contradictory to previous orders. Clarification here would be helpful.
That's not what that says. It's kind of, that language was in before, and it's kind of written in a backwards way. What it says is that the visitation guidance doesn't apply to them. So that means that they can come in. So that paragraph means that you can, using those parameters that are listed there, utilize these non-medical professionals.
Okay. And I believe the other ones that we haven't gone over are pretty much repeats. So I think we pretty much knocked out all the questions at this point. So if anybody else does have any further questions or anything else, which I'm sure they will with everything else coming out, you can feel free to shoot any emails over to Dalton, Deanna, or the Safe and Calm at leadingagemi.org, and we will make sure to get those questions answered for you. So we would like to thank Jonathan. We would like to thank Deanna and everyone else for joining us here today. And then we would also like to thank, I believe that we broke our record yet again and got up to 115 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Again, just a quick reminder that we do have our SNF Regulatory Day coming up tomorrow, and you can go ahead and head over to our leadingagemi.org website and click on the events tab. It should be probably the first event up is my assumption. You can go ahead and click on that and register right there if you would like to attend that. Other than that, we will have our next Safe and Calm webinar this Friday at 11 a.m. Eastern Standard Time. So I hope everyone has a great remainder of their Wednesday, and we will talk to you guys all soon. Thank you.